Hi everyone, I want to talk about acute cancer pain syndrome. Acute cancer pain syndrome. Is anyone around you having cancer, or yourself, or you are taking medication, or you are treating anyone with cancer? Sorry to hear about that, but let's go. Acute cancer pain syndrome could be as a result of iatrogenic. That is a word I don't like to hear because it's all about inflicting trouble as a result of laboratory or radiological investigations or treatments. In other words, this pain syndrome is caused because of interventions, medical interventions, either through diagnosis or the treatment in the hospital, at home, or at clinic. Also could be caused as a result of the disease itself. So is that iatrogenic or disease related in etiology? Androgenic causes are related to diagnosis investigations or the treatment. An example would be bone marrow biopsy. And another example is prostate biopsy transrectally, endometrial biopsy, or endoscopy with biopsy. They could all inflict pains. Androgenic causes could also involve causes secondary to arterial sampling, venous blood sampling, lumbar puncture that could give headache and pain, and of course biopsy percutaneously. Treatments or other interventions that could lead to pain will include suprapubic catheterization, nephrostomy with tube insertion, abdominal paracentesis, vascular embolization, bilateral stent percutaneously, chest tube insertions, injection site pain, and epidural injection pain. There's a syndrome called Hyperalgesia syndrome. Opioid hyperalgesia syndrome is essentially that there will be a paradoxical response to opioids, and it's going to occur where the recipient has actually become more sensitive to painful stimuli. Okay, the second cause of acute cancer pain syndrome, as I've said earlier, would be disease itself. And now let's talk about cancer-related cause. So it might be hepatocellular carcinoma that has ruptured. In that case, there'll be pain. There's possibility of pathological fractures from bone metastasis, particularly the vertebra or lumbar bones. In vertebra, there's going to be compression, fracture, and of course the lumbar bones in different ways. For example, multiple myeloma with osteolytic lesions, sending out calcium and phosphorus and making the bones to be weak and thin, leading to pathological fractures. Also, acute intestinal or biliary or rectally obstruction or perforation, maybe as a result of cancer along this particular system or the nearby or adjacent structures or secondary metastasis to these hollow vesicles. Cancer treatments suppress immunity and thereby leading to resurgency of latent epizoster. And of course, that may lead to shingles and post-herpetic neuralgia. Cancer could also cause thrombotic events, cause DVT, and DVT at both upper and lower limbs are possible. There's possibility of superior vena cava obstruction. There is a phenomenon called breakthrough pains. Breakthrough pains are transient flares In other words, the individual is on a long-term opioids, but suddenly there'll be pain while still on the medication. So we call it transient flares. It just comes up like that in between the long-term medications. It's likely going to be moderate pain and sometimes could be severe. It's associated with chronic pain and the patient is already on opioid, directly related to the cancer itself, and could be triggered by treatment or diagnostic tests as well. It is not pain caused by surgery or fall. So breakthrough pain is not secondary to fall, is not secondary to surgery. It is all related to cancer itself or diagnostic or treatment. How do we treat breakthrough pains? We have what is called rescue dosing. And in that case, we're going to use short-acting supplemental opioids. It's just like in the case of diabetes mellitus, and then you have sugar level fluctuating somehow, then you use fast-acting, rapid-acting, insulin to help out. So in this case, we're going to use short-acting supplemental opioids. I say supplemental because there's a long-acting regular or basal opioid that the individual is already taking. So must he have the fixed scheduled long-acting meds? Okay, but we're going to use immediate release morphine or immediate release oxycodone, immediate release hydromorphone or oxymorphone. We're going to calculate the basal dose, and when that is determined, we will use 10 to 15% of that basal dose as rescue dose of the immediate release morphine, oxycodone, hydromorphone, or oxymorphone as the analgesic to treat breakthrough pains. So while selecting medication for breakthrough pains, we will have a lot to choose from. You can start from phytonine, and if you want to use the Booker tab, that is Ventoria, dosage of 100 microgram is fine. Or if we are going for oral lozenges like Acute, that is still phytonine, at 200 microgram is fine. And if you want to choose the nasal spray, Lazanda, that is another form of fentanyl, is fine at 100 microgram. And if it is sublingual spray, you can use Subsys at 100 microgram. Or if you are going for sublingual tablet, you can use 100 microgram of Astra. If you don't want to use fentanyl, you can use oxycodone immediate release at lowest dose possible. And morphine is also available at 15% of the basal, but you have to use immediate release form. The opioids that we'll mostly use in cancer patient management will include fentanyl, morphine, hydromorphone, oxycodone, oxymorphone, and hydrocodone. You can check my channel for most of these drugs like fentanyl, morphine, hydromorphone are produced separately. The estimated opioid equivalency of hydromorphone intravenous 1.25 milligram is fentanyl patch 12 microgram. And if we are choosing morphine, the equivalent dose of 1.25 hydromorphone intravenously would be 8.5 milligram morphine. And if you are going for oxycodone, that is going to be 15 milligram oxycodone per oral. All those will be equivalent to hydromorphone 1.25 milligram intravenously. Somebody might ask, why am I on opioids? Why is my cousin, my brother, my neighbor, My coworker, why are they on opioids because of cancer, pains? Why not another medication? Okay, no problem. It's safe. We consider the safety and potency because the cancer pain could be excruciating and we need something that will really work. And you can use multiple routes: rectal, per oral, subcutaneous, sublingual, buccal film, spray, name it, even patch, and could be titrated. And you have many options to choose from. Very reliable and good for nociceptive pains. Neuropathic pain, however, might not be completely handled while on opioids. So sometimes, or most of the times, we combine opioids with adjuvants like tricyclic, antidepressant, amitriptyline, and I will select nortriptyline in elderly. You can also use gabapentin or pregabalin. You can use selective serotonin uptake inhibitors or venlafaxine or duloxetine. You can also use anti-epileptic drugs, even calcium channel blockers could be used as well. Okay, there's nothing having beginning without having an end. Someone is on opioids. He or she wants it to end. You don't stop opioids now suddenly. Please, you tail off gradually. And there will be withdrawal symptoms. So you handle the withdrawal symptoms. Adopt non-pharmacological measures at this period. Remember World Health Organization pain ladder. Opioids could be pure agonists based on the effects on mu receptor. Pure agonists on mu receptors are adromorphone, morphine, fentanyl, codeine, hydrocodone, dihydrocodone, oxycodone, levodopa, methadone, and meperidine. They are pure agonists. But here is the warning. When it comes to meperidine, it is less useful because of toxic metabolites. And when it comes to methadone, be careful. There's very long half-life, okay? Very long half-life that could be a big problem. If you don't manage that, you might be in trouble. And methadone can prolong QT as well. And there is variability when it comes to potency. So back to the half-life of methadone. Half-life of methadone could span as long as 30 minutes to 7 days. That is why when someone is on methadone, we don't increase the dosage just arbitrarily. The dosage is increased after 3 days. After 3 days, because the half-life could span as long as 7 days. So if care is not taken, you might be giving excess dose to someone on methadone. But don't be afraid. The doctor that will prescribe methadone must be highly skilled in doing that. So there's no reason to fear. You have problem when you go on streets to get it. Mixed agonists and antagonists on mu receptor will be buprenorphine, zofranol, pentazocine, naproxen, and desoxin. Buprenorphine has no ceiling effect for analgesia. Could be used as transdermal patch or in buccal formulation. Pentazocine and butorphanol have severe psychotomimetic side effects. And with that, I've come to the end of this first part of acute cancer pain syndrome. The next will be cancer pain syndrome and the treatment, part 2. There, we're going to talk more about all these medications and we'll be able to arrive at conclusion. Thanks for listening to my presentation. Kindly subscribe to my channel so that you can get these publications immediately they are released. Thank you.